Good morning. Today's CGR topic is assessing the burden of complication in early onset type 2 diabetes, prevalence and the predictor. We know that the diabetes is going concern globally, and especially in the low and middle income country, which include the India also. And India is the home to the second largest number of people with the diabetes in the world. So that's why it's often called as a diabetic capital of the world. Over last 1 decade or so, the rising prevalence of type 2 diabetes in early age or young people has got worldwide attention. And many of these young people have no early sign. They were undiagnosed until the serious damage occurred, and there was a frequently lack of information about the diabetes care and the risk factor. So these are very worrying factors. People with the early onset type 2 diabetes often have a more aggressive clinical course than those with the adult onset or early onset type 2 diabetes, or as compared to type 1 diabetes. Early onset type 2 diabetes is associated with the development in the midlife of major diabetes complication, which include kidney disease, eye disease, neuropathy, and the cardiovascular disease. So today in this CGR, we aim to give the overview of early onset type 2 diabetes, which is our major concern, and the data on the prevalence and predictor of early onset diabetes as compared to the late onset type 2 diabetes. This will be presented by Dr. Ayushi. These were her DM research topics also. However, before that, Dr. Nachiketa will give the current scenario of type 2 diabetes worldwide and in India in very brief. So I invite Dr. Nachiketa to give the overview of type 2 diabetes worldwide and in India.
As we know, type 2 diabetes is a fastest growing global health emergency in 21st century. Globally, 1 in 10 individuals are living with diabetes. And what is more alarming is that 1 in 2 out of these are still undiagnosed. Additionally, 1 in 9 adults have impaired glucose tolerance, and approximately 25% of these will progress to diabetes over next 3 to 5 years. 1 in 6 live births are affected by hyperglycemia in pregnancy. 3 in 4 people with diabetes live in low and middle income countries, and 11.5% of global health expenditure is spent on diabetes alone. Diabetes remains top 10 causes of mortality, and 67 lakhs of deaths are attributed to it. Since 2000, estimated global prevalence of diabetes in adults has more than tripled from 15 crores in 2000 to 54 crores in 2021. And if sufficient action is not taken to address this number is projected to increase to 64 crores by 2030 and jump to a staggering 78.4 crores by 2045. While the world's population is estimated to grow 20% by 2045, the number with diabetes, people living with diabetes, is estimated to increase 46% over this period. And it is estimated that 94% of this increase will occur in low and middle income countries, which includes India. India is one of the epicenters of diabetes global epidemic. In 2000, prevalence in our country was 5.8%, with 3 crore people living with diabetes. Fast forward to 2021, and this number has nearly doubled, with prevalence of 9.6% and 7.4 crore people living with diabetes. This is estimated to reach 10.8% by 2045. This has economic implications, like studies have shown that diabetes alone exhausts 5 to 20% of average Indian household income of the affected individuals. In 2015, average economic burden of diabetes in South Asia was estimated to be 1% of GDP. And with estimated prevalence rising, the economic burden is bound to increase. And this will put an immense strain on our resources. Diabetes in India is characterized by higher prevalence, occurrence at younger age, which is 1 to 2 decades younger than Western population, occurrence at lower BMI, and higher prevalence of coronary heart disease, and also higher risk of triple vessel disease and higher mortality due to coronary heart disease. A specific phenotype, Asian Indian phenotype, has been described. where for a given BMI, Indians have high waist circumference and higher visceral fat content. Indians also have higher prevalence of atherogenic dyslipidemia, higher insulin resistance, more intense pro-inflammatory cytokine milieu, lower physical activity, high intake of calorie-dense foods like refined cereals, and low intake of dietary fiber, fruits, and vegetables. Additionally, there are certain issues in management which are faced in India for diabetes management, which includes low level of awareness, high prevalence of undiagnosed diabetes, unaffordability of care, and paucity of trained medical personnel. Traditional complications of diabetes are well known, which includes microvascular complications like diabetic kidney disease, retinopathy, and peripheral neuropathy, and macrovascular complications like coronary heart disease, stroke, and peripheral vascular disease. But as there is advancement in diabetes management and longer life expectancies, a different set of complications are emerging, which includes cancer, infections, liver disease, functional and cognitive disability, and affective disorders. While duration of diabetes and level of glycemic controls are important factors affecting these complications, other factors include hypertension, dyslipidemia, obesity, lack of physical activity, and smoking. I'd now like to invite Dr. Ayushi to give an overview of early onset diabetes, prevalence of complications in this group, and present her data.
Good morning, everyone. So I'll start with a brief review about the early onset type 2 diabetes and the issues which we used to face in this group, and which helps us in understanding regarding the need to study this entity as a separate from the late onset. And later on, I'll present our data regarding the prevalence and predictors of complications in the early onset group. Early onset type 2 diabetes has been defined if the onset occurs in less than 40 years of age. And this age cutoff has came from the previous literatures, which suggests that this group has a higher prevalence of morbidity and secondary to the various micro and macrovascular complications associated with the diabetes, and also higher prevalence of mortality compared to the late onset group. And the importance for acknowledgement of the early onset diabetes is there because as this is the most productive year of the life, and as this is the most productive year of the life, and due to the diabetes and the associated complications, there is affection of the education as well as the employment of patients. Other than that, the increasing burnout due to the complications and the inflexible timing of the appointments in the healthcare services. And also, as many of the patients in this group already have the job constraints and the financial issues, together with the stigma of having diabetes. Like in India, especially the females are highly stigmatized if they are having diabetes. It leads to various mental health issues and also affects their family life. Second, as this age being the reproductive age, the increase during the pregnancy, the increase in the number of visits in the hospitals compared to those who don't have the diabetes, and also the higher the fear of having adverse diabetes related complications, and in the fetal complications, it also leads to other than that, there is an invisible evidence that it has been seen that in most of the regions, the type 2 early onset and the late onset are being managed similarly, despite of being this group having the more aggressive course. Coming to the prevalence part, the prevalence of early onset type 2 diabetes is rapidly increasing, and the estimated prevalence global as well as across various regions has been found between 4 to 8%. And one thing I would like to focus that the data suggests that India is contributing to around 1/5 of the global early onset type 2 diabetes cases. And this graph suggests that the prevalence of diabetes in 2010 in the early onset group was 2.5, and it has been estimated to be doubled by 2025, that is around 5%. So why there is a need to worry about this? As mentioned previously as well, previous literature suggests that there is a high risk of mortality and the morbidity in the early onset group. And it has been found that with 1 year increase in the age at diagnosis, it was associated with decreased risk of all-cause mortality, macrovascular disease, and microvascular disease by 4%, 3%, and 5% respectively. And regarding the prevalence of young onset diabetes, literature suggests that either it was comparable or more than late onset group. So as for the retinopathy, the prevalence was found between 9 to 48% in the early onset versus 18 to 30% in the late onset. Prevalence for neuropathy was between 8 to 26% in the early onset versus 7 to 42% of the late onset. Nephropathy prevalence was between 3 to 40% in the early onset versus 9 to 36% in the late onset. And for the cardiovascular disease, the prevalence was between 7 to 8% for the early onset versus 20 to 30% for the late onset group. So the pathogenesis behind this increased risk of complication in the early onset has been given as first is the higher insulin resistance in this patient. Second, it has been found that there is early loss of both the first and second phase of insulin secretion, because the studies suggest that there is accelerated loss of beta cell function in this patient, which is around 5 times higher than the patients who develop diabetes after 40 years of age. Third, there is a greater duration of exposure to hyperglycemia. So all these three factors leads to more exposure to hyperglycemia and increase in the complication risk. So keeping these all things in the mind, and as few studies in the India has compared the early and late onset type 2 diabetes group, and the clinical characteristics of the early onset cases remains clear till date. So our study was conducted to assess the prevalence and severity of complications in early onset versus late onset type 2 diabetes in our population, with the potential insights for prevention and treatment in early onset cases. Aims and objective of our study was to assess and compare both the micro and macrovascular complications in early onset and late onset type 2 diabetes group. It was a prospective, cross-sectional, single-center study. 1,304 subjects were initially included, and they were all all the consecutive adult patients between 18 to 80 years with a laboratory confirmed type 2 diabetes mellitus. It was a 2-year study period conducted from September 2022 till August 2024, and all the subjects had a comparable age and sex ratio to non-responders. Coming to our data collection, it included the demographic, socioeconomic, and anthropometric data, and the medical history, which includes the family history of diabetes, duration of diabetes, current treatment of the patients, hypertension history, dyslipidemia, and assessment of all the microvascular and macrovascular complications. Blood pressure diagnosis was made as per the JNC 7 criteria. Fasting blood samples were collected for the plasma glucose, creatinine, glycated hemoglobin, and lipid profile. Overnight urine samples were collected for urine albumin creatinine ratio. Coming to the complication screening, for the microvascular complication, neuropathy assessment was done using 2 scores, neuropathy symptom score and neuropathy disability score. Neuropathy symptom score was comprising of 4 variables. First is the presence of complications. Second, the site at which the patient has these symptoms. Third is exacerbation of the symptoms during the day or night. Third is the factors which were alleviating the symptoms. And all of these parameters were giving some points, and the combination of the points were done, and later the patient has been classified as having mild, moderate, or severe neuropathy symptom score. Similarly, neuropathy disability score, in this, the signs were assessed for the presence of small fiber and the large fiber neuropathy. And here also each parameter was given some points, and the combination of the points were done, and the patients were classified as being the presence of mild, moderate, and severe neuropathy disability score. Finally, diagnosis of neuropathy, diabetic peripheral neuropathy was made if the patient had moderate to severe signs regardless of symptoms, or mild signs with moderate to severe symptoms. For the nephropathy assessment, overnight albumin-creatinine ratio and estimated GFR was done, and the patient was diagnosed to have diabetic kidney disease if the two samples for the overnight albumin-creatinine ratio, which were done at 3 months apart, was suggestive of ACR of more than 30 milligram per gram, and or if the GFR is less than 60 ml per minute. Retinopathy assessment was done by indirect ophthalmoscopy by ophthalmologist by 90 diopter slit lamp by microscopy in the dilated pupil, and in some patient fundus photography was also assessed. And the grading was done as per the International Classification of Diabetic Retinopathy classification. Coming to the macrovascular complication screening, coronary artery disease was diagnosed if the patient already has a history of coronary artery disease with the documents available, and if there was no history and the patient presented in the OPD with the symptoms suggestive of the same, and or if the patient has abnormal ECG finding going in favor of presence of coronary artery disease, then a cardiology opinion was taken, 2D echo was done, and the diagnosis was made by the cardiologist. For the cerebrovascular accidents, diagnosis was made based on the history and the previous records suggesting of history of transient ischemic attack or cerebrovascular accidents, or if the patient recent presentation is with the complaint suggestive of cerebrovascular accidents. Similarly, the peripheral vascular disease history, it was based on the presence of claudication or rest pain, or if the patient has non-palpable peripheral pulses, or if the patient has abnormal ankle brachial index. If any of the three is available, then the confirmation for the presence of peripheral vascular disease was done by bilateral lower limb arterial Doppler, and the peripheral vascular disease was diagnosed if the same was suggestive of monophasic flow. So this is the flow chart which is depicting our subjects recruitment. 1,304 patients were visited to the investigators OPD, out of which 106 patients were excluded secondary to the presence of other causes for the diabetes. 270 patients were excluded who have the complications secondary to some other cause or hyperglycemia secondary to the some drugs, and those who have not consented for the study. So we had 928 patients, out of which 400 patients were belonging to the early onset group. After matching for the duration and gender, in the late onset group also 400 patients were there. So each group has similar number of patients. And the baseline demographics of the patient was suggestive of the age at presentation to us was significantly higher in the late onset group, and it is as expected. And as mentioned previously, the duration and the gender was matched in both the groups, although we found a higher prevalence of male population in our study, 65 and 62% in early and late onset. Socioeconomic status was also matched in both the groups. We found a significant prevalence of family history of type 2 diabetes in the early onset group. And this was matching with the basic pathophysiology, previous literature, which also suggests that these patients have a higher prevalence of family history of type 2 diabetes. Coming to the results, hypertension, which was diagnosed based on JNC7 criteria, it was found in 74% of the late onset group and 56% of the early onset group. One thing to note is that when the patient presented to us, the newly diagnosed cases were 19% in the early onset and 20% in the late onset group. And this is a significant number. Other important thing which we found was in the early onset group, 43% of the patient has hypertension within 5 years of being diagnosed, while 58% were having the hypertension within 10 years of diagnosis. We also found a significant prevalence of metabolic parameters, that is presence of metabolic syndrome, overweight and obesity, which were 85% and 80% respectively. Presence of abdominal obesity, which is a marker, which is an indicator of increased risk of cardiovascular disease, was present in 71% of the early onset group. Another thing which we found was presence of central obesity in a patient who had normal BMI was also present in 26% of patients. When we assessed for the management part, we found a significant difference in the requirement of insulin and more number of OHAs. That is, the insulin requirement and more than 3 OHAs was significantly higher in the early onset group as compared to late onset group. And the one more important thing which we found that after 15 years of diabetes duration, there was a significant difference with the requirement of insulin in early onset versus late onset group. As in early onset, 62% were requiring insulin, while in late onset, 41% were requiring insulin. Coming to the laboratory parameters, the glycated hemoglobin, which was assessed at presentation, was significantly higher in the early onset group. And the lipid parameters like triglyceride more than 100 milligram per deciliter, non-HDL cholesterol more than 130 milligram per deciliter, and HDL cholesterol less than 50 in females and less than 40 in males was significantly higher in the early onset group. And this data was matching with the absolute values of all the three parameters. So till now we were discussing about the initial presentation, treatment part, and the baseline laboratory parameters. Coming to the complication part, in the complications part, we found that at a median age of 44 years of presentation, about half of the patient has, in the early onset group, has neuropathy, which is considered to be the most disabling complications for the patient. And other than that, nephropathy was present in 1/3 of the patient, while retinopathy was present in 1/4 of the patient. And when we added all the complications, we found that a significant number of patients, that is 69% of patients, were at least having one microvascular complications, and all the three microvascular complications, increasing the morbidity of the patients much higher, was present in 8% of the patients. So recapitulating our data, we found that 27% of the patient has retinopathy, while the vision-threatening conditions like severe non-proliferative diabetic retinopathy and the proliferative diabetic retinopathy was present in 6% of the patients. Nephropathy we found in 1/3 of our participants in early onset, while the most problematic part is the presence of nephropathy in 25% of the patient within 5 years of diagnosis. Among the subjects with nephropathy, 34% has retinopathy. That is the two major complications were present in around 1/3 of the patient at presentation. Another thing we assessed with the difference in the age for the prevalence of complication, we found that within 5 years of diagnosis in the early onset group, at the age of 37 years, 18% of the patient has retinopathy, while 23% of the patient has nephropathy. And when we matched the age of onset of the similar prevalence in the late onset group, we found it at the median age of 55 years. Coming to the foot examination part, there is a high prevalence of high-risk foot, and this it was present in 42% of the early onset group. And why there is a need for consideration of this? Because high-risk foot, which occurs due to the various neuropathic, microvascular, and biomechanical changes secondary to the diabetes complication, it can lead to increased risk of foot ulcers and amputation in the near future. So this group requires this requires a better healthcare services. Although the diabetic foot ulcer was found in 3% of the patients at presentation. So this is all about the microvascular complication. Coming to the macrovascular complication part, we found as traditionally the macrovascular disease was being considered as to be in the late onset diabetes patient. But here we found that a significant number of the patients, like around 4% of the patients, has all the three macrovascular complications, that is coronary artery disease, cerebrovascular disease, and peripheral vascular disease. And when we have seen as a combination, that is the atherosclerotic cardiovascular disease, we found that it was present in 9% of the patient, which is a significant number. And the problem is that it might increase with the increase in the age of the patient. Then we assessed for the predictors of type 2 diabetes complication. And this was assessed using the bivariate logistic regression analysis using the backward limitation model. And we found that as expected for the peripheral neuropathy and atherosclerotic cardiovascular disease, early onset diabetes has a higher risk with the odds of 2 and that in the late onset diabetes, the risk of peripheral neuropathy and atherosclerotic cardiovascular disease were increasing by the odds of 2 and 2.3 respectively. While when we assess for the other parameters for the increase in the prevalence of peripheral neuropathy, we found that the presence of retinopathy was increasing the prevalence of neuropathy by 2.2 times, while the presence increase in the duration of diabetes by 5 years was increasing the risk of peripheral neuropathy by 1.5 times. And we found a significant difference in the gender as well, that the female population has 1.5 times higher prevalence of neuropathy as compared to the male population. For the atherosclerotic cardiovascular disease, we found that the presence of nephropathy was increasing the prevalence of atherosclerotic cardiovascular disease by odd of 1.7. And we also found a increase in the risk with the smoking. Also, although this was assessed only in the male population, but we found a significant odds of 3 with the same. So compiling our data, in short, in the early onset group, a significant patients has the family history of diabetes compared to the late onset, more use of the insulin and more number of hyperglycemic agents, anti-hyperglycemic agents, higher non-HDL cholesterol and higher triglyceride values and low LDL cholesterol. While late onset group has more increase in significantly higher peripheral neuropathy, atherosclerotic cardiovascular disease, coronary artery disease, and hypertension prevalence as compared to the late onset group. Although the equal prevalence was found in both the groups for nephropathy, retinopathy, cerebrovascular disease, peripheral vascular disease, and LDL cholesterol of more than 100 milligram per deciliter. This needs to be considered because the equal prevalence in both the groups was found at a different median age. In the early onset, it was 44 years, and in the late onset, it was 59 years. So there is a high risk of increasing these all complications in the near future in early onset group. So when we compared our data with the previous similar studies, although most of the studies were either the retrospective studies or the one which was done in Aligarh was an observational cross-sectional study, but in that also some data was retrieved from the records. And in some of the studies, they were not matched for the duration, which is an important factor for the increase in the prevalence of complications. So we found that prevalence of hypertension and neuropathy in all the studies were higher in late onset group as seen in our study as well. And the hypertriglyceridemia was significantly higher in one of the study in the early onset group, which is also there in our study. Although the other complication parameter data was heterogeneous, it was either more or less or comparable to the late onset group. So this being the strength of our study, because our study was completely a prospective observational study, all the patients were gender and duration matched. And we have screened for all the patients, except for 14 patients, which were not screened for the fundus examination, and 3 patients for whom albumin-creatinine ratio has not done yet. Although we had limitations too, because the glycemic control was assessed using a single visit values. This study was cross-sectional, so no follow-up was conducted. And as it was a single center study, at the referral center, so the result may not be generalizable. Concluding our study, so we found a higher percentage prevalence of neuropathy, nephropathy, retinopathy, and macro ASCVD in the early onset type 2 diabetes group. And compared to the late onset group, we found a similar prevalence of nephropathy and retinopathy, which highlighted the disease aggressiveness in the early onset group. Implications of this study being, as the individual with the early onset diabetes, due to their longer life expectancy, they are at higher risk of complications during the most productive year of the life. So early intervention with the improved glycemic control and regular follow-up, they may help to mitigate these risks and enhance the quality of the life in these patients. I would like to thank our co-investigators, Dr. Deepti Saxena, Dr. Alok Pratap Singh from Department of Ophthalmology, Dr. Ashwini from Department of Radiodiagnosis, Dr. Raviraj and Professor Naveen Garg from Department of Cardiology, Dr. Navya and Professor Ish Bhatia from Department of Endocrinology. I would also like to acknowledge our nursing staff, Saida Banu, Vipul Nigam, Lily, Tarun, Pooja Prajapati, and our lab technician, Anil Maurya, Neeraj Kumar, and Mohammad Rizwan for helping us out in doing vibration perception threshold and ankle brachial index in our study subjects. And also, I would like to acknowledge Department of Ophthalmology, Cardiology, Radiodiagnosis, Pathology, Nephrology, Endocrine Surgery, and Biostats and Informatics. Thank you.